Assalamu alaikum. Hello, clinical consultation day. First scenario, Mr. Peter Gardner, 70 years old man, present with numbness and tingling sensation. Please take history, examine the patient, address his concerns. Ready?
Yes.
Here you go.
Hello, I'm Dr. Abdullah. I'm one of the Al-Madla, one of the doctors here. Is this Mr. Peter Gardner?
Yes, doctor.
And you are 70 years of age.
Yes.
Mr. Peter, how are you doing today?
Doctor, I'm not so fine. I'm just worried.
I'm really sorry. To explain to you today, I will ask you questions. I will examine you, and I'll address your concerns, if that's okay.
Okay, doctor.
Could you describe to me what is the issue, please?
Okay, doctor, for the past 1 year, I've been having this tingling sensation, and numbness, and I've been very, very bothered, doctor.
Oh, I'm really sorry. Could you describe to me where is it exactly in the body?
Actually, doctor, I noted it started happening from the leg when I was about starting my car one fateful day, and I couldn't touch my pedal. I just noticed that I feel as if there was cotton wool in my foot, with my right leg, then later my left leg. And then even now, it's affecting my body, doctor.
Okay. How much this is impacting your life?
Oh, doctor, now I've been so down. I can't do anything at home again. I can see now I came with a wheelchair. I'm so tired, doctor.
Oh, I'm sorry. Can you describe to me what activities has been difficult for you?
Doctor, a lot of activity, doctor. I can't do my normal, gardening again because usually every two fortnight, I usually do my gardening, clear my garden.
Mm-mm.
I can't do that again, doctor.
Mm.
I know that I've stopped working for the
Mm.
past 5 years now, and
Oh
despite
God,
that, yeah.
okay.
Mm.
Um, so I will come back to your job.
Oh,
Um,
okay.
I will try to help you as much as I can. So can you describe to me, is there any weakness?
Pardon?
Is there weakness also?
Yes, doctor. There's weakness, doctor. Yeah, there's weakness. There
Okay,
is.
where is the weakness about in your body?
Um, both my hands and leg, but
Okay,
yeah.
so was it also started from the leg, the same as the numbness, or so where did it start and now where did it
Um,
go?
yes. After the numbness, and that same day, before towards the evening, started noticing weakness. And it has been progressing, doctor.
Okay, I see. And have you sought any medical advice all this year?
Actually, I've not because I feel I don't like coming to the
Okay,
hospital, but because my
okay.
wife something happened. Okay, yeah.
Oh, ah, okay. And okay, is there any so where is the weakness now and where is the numbness? Where is it now?
It's still there. I'm still having a numbness and weakness in my legs, and also in my hands, doctor.
And hands, okay. And
Yes.
have you noticed any difficulty in your swallow or breathing? Swallow first.
No, not at all, doctor.
Okay, and breathing,
No, not at all, doctor.
especially when you are lying down in bed at night.
No, no, doctor.
Okay. Have you noticed any headache?
No, doctor.
Have you noticed any change in your difficulty in your speech or speaking?
No, doctor.
Okay. And have you noticed any numbness in the face
No, doctor.
or any any hearing issue? Change in your
No,
hearing,
doctor.
change
No,
in
doctor.
your sense of smell.
No, doctor.
Okay. And um, have you okay? Coming back to this numbness, anything make it worse?
Doctor, it has been there. In fact, it's getting worse than initial when it started.
Okay. And
Yeah.
and the weakness has been anything make it worse? Anything?
I can't say I can't think of anything, doctor.
Okay. Anything about these make it better? Have you noticed?
Not at all, doctor. It's not getting better.
Okay. Okay, I see. And have you noticed any pain ever in your especially in the back? Have you got
No,
any
no,
pain in the body
no. So
or
occasionally I feel pain. Yeah, occasionally I have this pain that I usually have in my hands, but that was a long
pain
time
in the
ago.
hands?
In the hands, yeah, hands
Okay.
and legs, but that it has gone now. It has gone
Okay.
now. Mm.
Okay. Okay. And have you got so that started 1 year?
What exactly?
This condition started 1 year,
Yeah,
you said, right?
1 year. Yeah, the numbness
So
and tingling sensation.
has been ongoing all this 1 year, or is it something comes and goes?
It has been ongoing, doctor. It has been there. It has been there.
Ongoing, okay.
Yeah.
And has it ever been improved and then came back worse, or is it worsening
Most
all the time?
It's just there. It hasn't,
It's
initially
just there,
yeah,
okay.
and it's progressing kind of.
Progressing and it
Yeah,
doesn't go.
yeah.
Okay.
Mm.
And so have you noticed did any food for any particular make it changing or something? Any
No,
food? Okay.
no, no,
In the end of the day or in the morning, for example?
no, doctor. No, no, no,
Okay.
doctor.
Have you got any before that year? I know that's long time and it's difficult to remember. Was there any like loose motion or you got any cough or any infection anywhere? Do you remember?
Um, Most likely, but I can't really remember. It's possible because I know definitely before that time, I think I had some complaint. Was not some little bit of I was feeling sick that period anyway, but I just felt that it's normal thing. I can't remember what I was having there, but I think I had
Mm,
some sickness before that time. Yeah, hopefully I do.
okay. Okay. I see. And okay. Have you got antibiotics that time? Do you remember?
I can't remember, doctor. I can't
Okay,
remember.
that's fine.
Yeah.
And can you describe to me if you have any past history of known medical condition?
Yes, doctor. I was diagnosed of rheumatoid arthritis for the past 20 years now, and I've been on
Mm-hmm.
medication. I also have high blood pressure, which I've been on medication too, and then I have atrial fibrillation too. I
Mm.
also have medication.
Okay. And are you taking the blood thinners?
Yes, I've taken all my drugs. I'm compliant with my drugs,
Okay.
doctor.
For the rheumatoid, was there anything how is the control of it? Is the doctor
And
happy about that?
yeah, the doctor has been the last time although for the past 2 years now, I've not seen because I've not seen my doctor because he has been taking, I've been seeing him for the past 20 years since I started. I was diagnosed, but for the past 2 years now, I've not gone for checkup. Yeah.
You're not what?
I've not gone for checkup for the
Okay.
past 2 years.
Mm, okay. And okay. And have you got any medications that you are on
Yes, these are my medication. I've sent my medication in the group.
in
These are
the
my medication.
group?
Yeah. Sorry, in the chat,
Oh
in the
yeah.
message box. You've seen
Thank
them?
you. Okay, yeah, I saw them. Thank you.
Yeah, these are my medication. Yes, doctor.
Any over-the-counter medication that especially before your symptoms started, have you been on any over-the-counter medication? Things
These
from
are
the chemist?
these are the drugs I've been taking before, for the past, so many years now. Yeah,
Okay,
these are the drugs. Yes, doctor.
okay.
Mm.
And I see. Okay. Have you got any? I will ask you. Have you got any high blood sugar, for example? Do you know
No,
of?
no, doctor. No.
Okay. Do you smoke, or have you ever
Yes,
smoked?
I've been smoking I have 20 packets history of
Mm-hmm.
smoking.
Mm,
Yeah.
okay, and I'm sorry, I want to tell you that it's really important it's adverse on your health, we will do our best to help you to stop smoking. Smoking is not good for your health, and it's better to try to hold it as much as you can.
Okay,
To
doctor.
stop, actually, yeah.
Okay,
And
doctor.
we can help you with that. Any alcohol use or
No,
drink?
I don't. I don't take alcohol because of my
Okay,
religious belief. Yeah. No, I don't.
not before even.
No, not at all.
Okay. And what job do you do?
I've retired, doctor. I
You
used
told
to.
me 5 years
Yeah.
ago.
Yes, I used to be a coach in the. I used to coach the under 17 basketball, team.
Oh,
Mm.
and okay. So is it because of this condition you've been
And
retired?
when I was diagnosed with rheumatoid arthritis, I started taking medication,
Mm,
and because of
mm,
that, I don't want to involve with some. I
okay.
just retired normally. Yeah, I felt I'm
Okay.
getting old.
Okay. I'm sorry for
Mm,
that.
no
We
problem.
will try to help you if you need any support. Um,
Okay.
okay. And do you have any trauma, or like have you fell on the ground
Yes,
or on
yes,
your, yeah?
yes. I've had fall about 4 times now.
Oh,
Yeah, yeah. And
okay. How
because of the last one I had, that's when my wife asked me to come to the hospital. Yeah,
how did you
yeah.
fall?
It's just as if I was in the kitchen. I slept. Yeah, just as if I step on top banana peel.
Okay.
But while there's no
Okay.
banana peel, but I just
Have you
assume
lost
as pardon?
have you lost your consciousness?
No, I didn't lose consciousness. I
Okay.
just fell
Okay. Okay.
down
Okay.
as if I just sleep on the banana, but there was no
When
banana on
when
the floor.
when was that?
That was about 2 weeks ago. The last one was 2 weeks
Oh,
ago. Yeah.
and have you injured yourself?
Yeah, I have some, yeah, I had some bruises in my body, but I think I'm okay.
Okay. Okay. Okay. Okay.
Mm.
Have you got any allergy to any medication that you know of?
No, doctor.
Okay.
No.
And okay. So do you drive?
Because of my condition, I don't drive again. I don't drive
Okay.
anymore. Yeah.
Okay. I will start examining you, and I may ask
Okay,
you
doctor.
in the middle if that's okay.
Okay, doctor.
I will ask for updated vital signs and lying standing blood pressure.
Okay,
Mm,
my vital signs are normal. I want to take my BP standing on. Okay, good. You check it on standing and on sitting down. It is 120/80.
okay.
Mm.
Okay. And so I will start by also okay, I'll start in the hands, any wasting, any clubbing, and I will
Okay.
look for the pallor,
Doctor
jaundice.
Doctor Bazin can send the picture of this of the um
Okay,
Do
I
you
will
have
share
any
it
weight?
now.
uh,
Do you have any weight
uh,
changes?
weight changes. Not at all, doctor.
Any
Not at all.
cough?
Cough? No, I
Any
don't.
shortness
No
of
cough.
breath? Okay, I asked
Shortness
you
of
that.
breath.
Any?
No.
Have you got any issues with the loose motion or being harder than usual?
No, not at all, doctor.
Have you got any difficulty in control of your water work?
Waterworks? No, not at all.
Any? Okay. Okay. I will start check the legs. Is he able to walk?
Suppose 2 minutes
Um,
left, but I will add
yeah,
2 more minutes
I can
after.
walk. I can try to walk,
Okay.
doctor.
Okay. I will examine the. Okay, I'll check the walk.
I should walk. Okay, when I'm walking, I have a taxi gate while walking.
Exit gate. Okay,
Mm.
and I will check the. Okay, I will. Okay, attack the gate. Okay, I'll ask him to. I'll check the tone. I'll check first if there's any pain,
Want to
and
the
then
pain? I don't feel pain. You want to check the
okay,
tone?
tone
Okay, okay,
and reflexes.
okay. The reflexes there's what a reflexia on
Reflexia, even with reinforcement.
both the knee and ankle. Yes, a reflexia.
Even
Then
with reinforcement. Okay,
mm, tone
and tone
the,
and power.
the the power is reduced.
So tone.
Um,
So yeah, power. How is reduced and
uh,
where?
uh, power is 3+ in the
Three plus in the
yes
hips
over
and in the knee,
yeah
around the
in the knee,
knee,
yes
flexion, extension, and also the ankle. And
yes
plantar response.
Plantar response, like I said, is a reflex here. Is normal.
No,
the plantar reflex is normal. Is
okay.
flexor.
There's no a clonus, and
Clonus.
I will check the. I will also check the.
clonus. The clonus is normal. No clonus.
Okay,
No clonus.
I'll check the sensations. So light touch going from the legs. Especially, I'm focusing. Is it there is level or there is no level? So is it upper the anterior superior iliac spine or below anterior superior iliac spine?
There's the sensories on pinprick. There's reduced pinprick sensation bilaterally.
Up to where?
Yeah, up to the anterior iliac spine.
So is it in the level exactly?
Yeah, no, but no
Okay.
level, no sensory level.
Okay.
Proprioception.
Proprioception.
Which of the proprioception is reduced to?
Yeah. So is it reduced up to where?
Yeah, up to the ankle.
Up to the ankles. And
Yes.
okay, the upper limbs. I will quickly just check the. So I will check for the. Okay, I'll check the pinprick also. Upper limb, is it involved?
Upper limb, yeah, upper limb is involved. Yeah, there's reduced in the hands up to the elbow joint.
Okay, and I will check ideally the neck. Is he able to shrug his shoulders, or is it weak?
The shoulder. Yeah, when you shrug the shoulder is normal. You can shrug the shoulder.
Normal, even with proximal myopathy testing.
For example, I don't understand even what do you want the patient to do?
So I'll check with forced. I will force the power against proximal arms extension, and I will see if there's any weakness.
Yeah, the answer is just 4. It's 4 plus.
4 plus, okay. And also I will so I will look in the hands also for sorry, I will ask him to say I'll see the the uvula and the throat, if there's any normal looking uvula and the tongue.
The uvula is normal, the tongue
and the tongue, any fasciculations and okay.
No fasciculations.
Okay, so sorry, any fasciculations while I'm examining the legs and the upper limbs?
No fasciculation.
No fasciculations. Okay. 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 So, Mr. Yeah. Mr. Gardner, what is your concern?
Doctor, what do I have, doctor?
After I have had this assessment, I have the possibility that there is this worsening symptoms that you have is mainly from a condition, worsening condition causing the body's defense system attacking your cables, the cables that's running that control the movement and the feelings in your hands and legs. But I'm afraid that this condition is actually a worsening condition, and we will work as a multiple team, a group of doctors. We will try to help you to manage the condition as much as we can.
Okay, doctor. Doctor, is it something that is my children can have the same condition?
There is the possibility actually that if there is something in the family happening, that there is a risk of the same family condition. Although I need to ask you more about that. Is it the same symptoms or not? But that's maybe there is a risk of when you get. It could be the same family condition, but if that depends on what condition I'm sorry, I'm not very clear about that. But
well, I mean, is it something that is I mean, is it something that is hereditary? Can my children have the same thing?
That there is a possibility actually when you get a condition that your family will your offspring will get there's a high risk of getting the same issue.
Oh, okay. Thank you,
Okay.
doctor.
Yeah, time is up. 4 minutes extra. You can start
Okay.
exam question, Dr. Henry.
Okay. Can you present what are the positive findings you got in examination and differential diagnosis of the patient? Can you please present your positive findings and differential diagnosis?
I don't know
Hello?
the voice.
Dr.
Yeah,
Abdullah. Yes,
I wasn't.
present the case. Present the case.
Okay. So this is Mr. Peter Gardner, 70-year-old gentleman. He has a known condition of rheumatoid arthritis with a recent not being good follow-up, not poor follow-up recently, and hypertension and atrial fibrillation. He's on medications and blood thinners. He has a 1-year condition of progressive ongoing ascending sensory and motor worsening symptoms of sensory and motor numbness and weakness. On examination, he has a picture of he has a picture of a lower motor neuron picture, lesion of grade 3 weakness in his legs and throughout the range of movements, with also impaired modes of impaired fine touch and pinprick, and up to the anterior superior iliac spine, and also he has impaired proprioception up to the ankles, and there is ataxic gait. There is involvement of upper limbs, and also I could appreciate there is features of widespread widespread bruises as a result of anticoagulation. So my impression is that first differential is that this is a chronic inflammatory demyelinating polyneuropathy. Second differential is other conditions of neuropathy in terms of such as other possibilities of spinal cord lesion causing radiculopathy, or could be toxin-related neuropathy, although I couldn't appreciate that in the history. There is vasculitis risk in this gentleman, given the history of rheumatoid arthritis with recent not regular follow-up, actually. Vasculitis related or paraneoplastic related neuropathy. But the clinical presentation is quite characteristic, being ascending.
So how will you investigate this patient?
Investigation, ideally I will, I'll start with basic blood tests, looking for blood tests, if there's any anemia, especially he's on blood thinners, if there's any raised inflammatory markers, ESR, and any evidence of infection, although no symptoms currently indicating that, so such as CRP, white blood cells. And also I will look for liver function test, looking for any evidence of metastatic or related raised transaminitis, or also any associated liver disease, especially with the autoimmune condition. I also look for kidney function tests, as uremia can lead to such symptoms also. And also I need to do chest X-ray, looking for any mass or tumor lesion, and also
how will you manage the patient?
nerve conduction studies. and EMG. To manage, ideally, this gentleman should have a multidisciplinary team approach, essentially with advanced nurses, occupational therapy, physiotherapy, in terms of his mobility, and he's as clearly affected with this illness. And also, he will need neurology input and follow-up. Also, we will need rheumatology to be involved. Given his neuropathy, he may benefit from, according to the investigations found, whether there is any intravenous immunoglobulins that, according to the neurology team and trial, and also we will see the follow-up results. And also forced vital capacity here is essential, and follow-up for the lungs, especially the progressive involvement. Yeah.
All right. Thank you so much. You did very well. But
Okay, Dr. Henry, I want to repeat the differential. Dr.
Okay.
Abdullah, give us 3 differential.
Yeah, chronic inflammatory demyelinating polyneuropathy. So that's the top. So that's the diagnosis. Differential diagnosis here: ascending neuropathy from the autoimmune related, especially here rheumatoid arthritis. Other differential is paraneoplastic condition. Paraneoplastic neuropathy. Other differential is substance or toxin related ascending neuropathy. For example, such as I forgot the name actually. That's
okay. You can mention drug induce can cause.
Yes, absolutely. Yes, he's on medications. I think that can cause. Yeah.
So, which medication do you think you are thinking of?
I'm not sure. We will need to revise with the pharmaceuticals here. I wasn't sure if methotrexate or adalimumab or any.
Okay.
Yeah.
All right. Actually, this was my case, my long case in the exam.
Oh.
This was my case. One of my case, my long clinical case. I failed this station very well.
Oh.
And the reason why I failed it because of what same thing you make time management. You took 12 minutes plus for only history taking.
Yeah.
Which that you can't in this kind of case they have this kind of findings. There's no way you can use 2 minutes or 3 minutes to examine the neurological system in this patient. You have a comment. Sorry.
I didn't. I should have timed myself. I went to the screen of Dr. Basim and then I was surprised it's 11 minutes. So what part I exactly detailed? You noticed that I detailed more than usual in the history.
In the history, in the introduction, you spend time in the introduction, telling me which is in welfare, you get a full mark in welfare. You get the 4 mark in welfare. In the history taking, fine, in the course of the it didn't rule out endocrine function in this patient in your history, which is key. It didn't rule out family history in this patient. It didn't rule out any issue of past surgical history. You know, as of recent hospitalization, it did not rule out, the blood transfusion, although which was unlikely in this case. Then also, the issue, other causes in this case, like what they told me in my differential diagnosis, what they said, they said, okay, metabolic, it didn't rule out, although fine, patient does not have, you ask diabetes, you have alcohol, none of them was there. Medication. They asked me, I mentioned medication induced. They now asked me a question. Which of the medication am I thinking of? I mentioned methotrexate, but I was wrong. The answer was adalimumab. That was what they were looking for. Adalimumab, which is an immunology, which is what is like to be the differential diagnosis in this case. And another thing that they sent over as one of the top differential diagnoses here is amyloidosis from chronic rheumatoid arthritis that he has been having for over 20 years.
Okay.
You know, chronic amyloidosis, which can be either the AL subtype or the ATTR subtype, depending on how it's present. Then, like you mentioned, paraneoplastic syndrome is possible, but there's no issue of weight loss here. You know, no other things to suggest paraneoplasty outside the cigarette smoking. That was significant here, beautiful. Then also, you know, also you rule out. You didn't ask of what they call it. Okay, like the surgery, you didn't ask of surgery. I mentioned that it could also be vitamin deficiency, vitamin B12.
Yeah.
You know, patient has long-term methotrexate, you know, although he is on folic acid, you see the you know, and then when you mentioned the issue of the bruises that you said you induce the bruises to warfarin, and this patient say he has been having fall. Could it be due to the falls he has been having?
Yeah.
So don't just you know, assume that it's due to warfarin because it's on warfarin. It's possible, but you not measure examine the heart. He has atrial fibrillation. Definitely, he's on Bishop Polo. He's on. He didn't talk anything about the heart. Even your history lacks heart manifestation, despite the fact that he has hypertension, he has atrial fibrillation. He told you that he should just, you know, knock it out and go ahead. The fall could be for the peripheral neuropathy, basically. The fall could still be from cardiovascular. But thank God you checked for the BP on standing and on sitting. Beautiful. I just marked that one good for you. That was a very good thing you did in the examination, which you know what you want to say it in the exam. The examiner will say go ahead, but they'll just tick it for you. You've done very well in that case. But by and large, it was good, and there are a lot of things, you know, you have to rule out in this case. Thyroid function, you didn't rule out thyroid function, like I said. Hyperthyroidism, you know, these are the things. Renal failure, you know, like I said, vitamin B6, which is unlikely in this case. With either excesses or deficiencies can cause similar pattern. You know,
what is it? Sorry,
vitamin B6.
Oh yeah.
Yeah, either excess or deficiency can cause it. You know, copper deficiency are part of the metabolic can also be a cause. You know, if porphyria can have the same pattern, however, it's going to be more of intermittent, and definitely it can be it should be issue of pain alongside. Then also other what do you call it? I think these are the other things I want to really outline. Then in the examination, you should have just examined the joint to the rheumatoid arthritis, the joint, and see if you know, and see the joint too. But usually it's a very difficult case because when I entered the station, what came to my mind was the bruises I saw in the man's hands and leg. I was confused, and there was a lot of things there. You know, you have to check in fact, doing just the examination alone can take up to 7 minutes. If you want to, the examination alone in this case can take up to 7 minutes. So if you can do your history,
very focused,
very focused history within 7 minutes, 8 minutes. So you have time to examine this patient because the patient has a lot of physical findings, and those ones the examination will give you 4 marks in the exam for physical examination findings. You know, you have to look at the bruises, check if there's any scar, ask for surgeries, and also look at like you said, the gaits, which is good. Check the motor function. All those things will take time. Not the way you are saying it in the meeting now. In the exam setting, to take time.
Yeah.
You know, but like you did very well, I must confess. In fact, you did. I didn't perform the way you perform now. To be candid, I didn't perform as good as you performed in this presentation.
Thank you, Dr. Henry, but that's online. That's only online, which is easy.
You did better, far better than me, because you know I failed this confusion woefully. They gave me 6 over 28 in this station.
Oh my God!
You know, it was a veto fail. That was part of the reason why I failed the exam. It was a veto fail.
Was it because not getting the signs, or like I'm sorry for that,
yes,
but like
no problem. I got the diagnosis right. I got peripheral neuropathy, no doubt. I mentioned drug induced. I mentioned those things, but probably because he said my history was not complete. In the history, they gave me 1 in the history examination. They gave me 0 in examination because my examination was zigzag. I didn't check for tone. Because I was trying to be in a hurry to finish everything. So
Yeah.
in the virtue of me becoming in a hurry to do both the joint examination and the neural, I just my examination was haphazard.
I
I
will
did the
show
gate.
you
I did
after
the gate.
they are actually, you did the gate. Perfect.
I did the gate. So I did the gate, but I didn't do the tone. I did the
Dr.
sensation,
Henry,
but yet
what was
they still give
the
me
case written in the feedback? What is the
in the feedback.
case?
It was peripheral neuropathy. Then
Yes.
one they put metabolic, two medication, three inflammation, and four amyloidosis.
Okay, so these are the differential. And
Yes,
the peripheral nerve is supposed to be stocking distribution. You mentioned up to the iliac
yes,
spine. Is
mm,
it?
But
yeah.
still, we can consider like it's
No,
below the
and
celiac spine. You said, right? Like,
yeah, but no,
it,
it's below the iliac spine. Like I said, not above the iliac spine. It's below the iliac spine. It's a symmetrical bilateral, the symmetrical, distribution starting from the leg down. It ends around the up to the thigh. I couldn't get anything. So the yeah, up to the thigh, I couldn't get anything up to the thigh. Then the hands too, I couldn't get the hands. Although in the exam, I couldn't even I didn't examine the hand because of time. But I only examined the lower limb. I
Okay.
definitely in the lower, I didn't complete the lower limb. But definitely the most likely because of the history, most likely is the people with CIDP, like what you said, which is the inflammatory part of the diagnosis. But what they gave me in the feedback was one, they put metabolic, they put medication, they put inflammatory, and they put chronic RA due to amyloidosis, and then they now put query brand neoplastic.
hmm,
Okay. Thank you,
Mm,
Dr. Henry.
yeah.
So it's now the case is clear, but I will comment on Dr. Abdullah
Okay.
performance.
yeah,
Okay.
please.
Again, Dr. Abdullah, you took long, first of all,
Yes.
and you did very long history and analyzing of the complaint. Even you ask about what was the weakness or the tingling at the minute number 6.
Uh,
What we are asking whenever you have a complaint, the onset, course, duration, what increase, what decrease, right? But you ask
yes.
what increase and what decrease at the minute 6. I don't know what you went out of this. You deviated away from the topic or from the
Mhm.
complaint, and you ask about other finding and other things. Focus first to analyze the main complaint. When it started,
Okay.
how it was it increasing or decreasing, stationary, constant. What make it better? What to make it worse? And how that
Mm.
affecting? If you want to ask about the impact,
Mhm.
but I think you can ask later on in the do you question what's your job and do you smoke, do you drink alcohol, do you drive, but you start these question early. You didn't ask about constitutional, maybe at the end in a change of your weight, but supposed to be earlier according to my approach. If you have your
Exactly,
approach,
exactly. No, no, you are right.
it's okay, but
Constitutional is essential. Yeah.
yeah, so you have to ask about them and the relevant system. You ask about hearing, vision, and so on. So CNS, the past medical history here is very important. There is history of rheumatoid, there is history of hypertension. I don't think if you cover all the questions related to them, how is the control? And the last thing, any medication list, including more than 5 medication, this is called polypharmacy. Okay, this is the definition of polypharmacy. Any patient taking more than 5 medication, it's called polypharmacy. What the importance of this? Blindly, with any complaint, you can say drug induced. Believe me, you can get
Nice.
the differential. One of the, if your differential will be correct, whatever the medication can cause, what the name of this medication can cause the side effect, but you can say it's side effect of medication. Maybe it's polypharmacy. I'm not sure about which medication can cause this. However, I could think about drug induce. That's it. You can get good mark from the differential, even the clinical judgment. Because any patient having a lot of medication, 5 and more, he has to be arranged or he has to know about the interaction. He has to know about the side effects. Many side effects happen whenever you have new medication. Even during the history taking, you can ask, do you think these symptoms appeared after starting this medication? Or you can ask
Okay.
when exactly. It's 5 months ago. Okay, when you start this medication, one by one, you will have one of the medication that appeared. The side effect appeared after commencing this medication. So you can say definitely this is one of the differential diagnosis. Okay, plus what we mentioned, chronic inflammatory demyelinating polyneuropathy, or vitamin deficiency, or paraneoplastic, plus the drug induce. Okay, this is the case, I think. But the history, I cannot judge on the history because you talk long, you miss a
Yeah.
lot of questions. The system
Yes.
examination also,
Systemic review.
the systemic review didn't ask at all.
Yeah.
You ask
Yeah.
about even the skin rash. You didn't ask about the musculoskeletal.
Mm-mm-mm.
The joint itself. It's a matter of how to be more speed, more fluent, to ask the question quickly,
Mm.
briefly, without going through the all details, in order to have a look on all the systems. I mean system review, constitutional, the past medical history and surgical history. Even here, you didn't ask about the family history, social,
Yeah.
occupational. Okay, so take care. You have to train more and more in order to
Perfect.
fast this. Okay, Dr.
Thank you so
Abdullah, you can
much.
post. Yeah, most welcome. Post your scenario.
Yeah, I'll.
Okay, Dr. Shema, the case was tingling, peripheral tingling or tingling and numbness. It was peripheral neuropathy due to adalimumab. Medication induced, and also there is possibility of chronic inflammatory demyelinating polyneuropathy, CIDP. These are the differential of our first case. We'll start now the second case.
Excuse me, Dr. Basim,
Yes.
can you explain more what is meant by the constitutional symptoms associated during history taking?
Yeah, there are 5 questions. Okay, constitutional symptoms means or B symptoms. Some doctors are mentioning like this: B symptom or B symptoms. What are they? Loss of weight, loss of appetite, any feeling of night sweat or high body temperature, and lumps or bumps. These are the whenever you have patient with these constitutional symptoms, means you have serious infection, you have cancer, you have connective tissue disease. So
Should
there
I
is
ask routine?
routine. Yes, every case you have to ask.
Mhm. This is before
It's
systemic review, yeah.
yes. You can check my approach down in the chat box, the photo, the white photo. How you can start the questions. It
Mm.
comes it comes after analysis of the relevant system. Why? Because I can put one of my differential, in this case, serious condition like infection, HIV, TB, or cytomegalovirus, or I can think about cancer, and I can think about connective tissue disease. These are the disease can give me the features or the constitutional positive finding of constitutional symptoms. By putting if you have both positive any of them, you can put them as one of your differential.
Okay, thank you very much.
Most welcome, Dr. Hassan. Okay, Dr. Abdullah, you post your scenario.
Yeah, yeah, I did.
Okay, Mrs. Julia Smith, 50 years old, with complaint of cough for 1 year. You ready, Dr. Henry?
Yes, I'm ready.
Okay, reset the timer. Any question from others before starting this scenario? Anyone want to add any comment or question? Okay, now we can start. Reset. Here we go.
Hi, I'm Dr.
Hi.
Henry, one of the doctors here. I'm here to see you. I'll be taking an history from you and then examining you. I'll be if you in the course of my discussion, if you have any query to ask, I'm going to address it. Can I
Thank
confirm
you.
your age and name, please?
Yes, I am Julia Smith. I am 50 years.
Oh, okay. I understand that you are having cough for 1 year now. Can you tell me more
Yeah.
about this cough?
Yes, it's actually making green phlegm or sputum, and it's something that has been ongoing actually 1 year, and it's quite bothering me. So I was referred from my GP. He advised me to come to the hospital I'm sorry, to come to this clinic to be assist with you.
Okay.
Um,
So for the past 1 year now, you have been having this cough. Is it getting worse by the day?
not really.
Okay. Have you had similar cough before like this in the past?
No, it was different. It wasn't cough. I had symptoms of like when I was child.
Okay.
Yeah.
Okay. So what was the condition? Was it diagnosed?
I was seen by GP. I was diagnosed as asthma that time, but things recovered.
Okay. All right. So sorry about that.
No worry.
After this cough, is the cough, is it little or is much? How do you quantify the amount of cough you produce?
It's quite bothering cough actually, and it's similar to irritating cough.
Okay.
And then I have this phlegm also, green phlegm.
Green film. Okay. Any blood stain?
It's not a lot. Answering your question, it's the phlegm is not a lot.
Okay. Any
It
blood
comes
stain?
from my nose.
Any blood?
Never. There is no blood at all.
Okay. Say it comes from your nose.
Anything come? No, nothing comes to my nose.
Okay. Okay. Any chest pain?
No.
Do you know of anything that you do that make the cough goes away?
That's a good question. I don't know. Like what?
Okay. Does the cough worsen in any time of the day, that morning or evening?
No, not any time of the. It's the same.
Okay, it's the same. Okay. Okay. Do you have any chest pain? Uh,
Any
any shortness of breath?
no shortness of breath. No.
Okay. All right. Do you have any fever?
It's similar to fever. It's like a sweat at night, and it's happening from 6 weeks ago.
6 weeks ago. Okay.
But it's not fever, like it's not
Okay.
like measured. Yeah.
Okay. So this greenish sputum this greenish phlegm that you produce, for how long have you been noticing this greenish phlegm?
1 year. Yeah.
The greenish 1 year. Okay. So sorry.
Yeah.
Do you have any increase in weight or loss of weight?
No, the same.
Okay. Okay. If I may ask, do you have any family, any past medical history, any medical problem you're managing before now?
No. I have only that
Outside
child as an.
childhood asthma.
Sorry.
Okay, asthma. Only the childhood asthma, right?
Yeah. Apart from
Okay.
that,
Any
I'm
surgery?
I'm good.
Any surgery?
No.
Okay. Any recent hospitalization?
No.
Any blood transfusion?
Any blood transfusion? No blood transfusion.
Any allergy?
Um. No allergy.
Any medication? Are you on any medication?
No.
Okay. Any over-the-counter medication?
Over the counter medication. No, I'm not over the counter medication.
Okay. I want to ask you some yes or no question now, if you don't mind. Do you have any headache?
No.
Loss of consciousness?
No.
Problem with your vision?
No blurring vision. No.
Okay. Okay. Do you have any problem with smelling or smelling or sensation?
No.
Okay. Any mouth sores?
Any mouth sores? No mouth sores. No.
Okay. Any bleeding from any part of your body?
Any bleeding?
And
No.
any
No
neck swelling?
bleeding. No.
Any neck swelling?
Um. No. No swelling. No.
Okay. Any hot or cold intolerance?
No.
Any pins and needle sensation?
No.
Any skin rash?
No skin rash.
Okay. Do you have um reason of the heart?
No.
Okay. Out of the water works? Any problem with your water work?
No change in the watermark.
Okay. Okay. Do you have any lumps and bumps?
No.
Okay. Do you smoke?
I stopped smoking actually on the age of 30 years, like
Okay.
20 years ago.
Okay. How long did you smoke before you stopped smoking?
I was actually a smoker of 5 cigarettes per day.
Okay. Do you take
Uh,
alcohol?
no,
Okay. Any recent travel
any no I no yeah I can't. I traveled actually on vacation
before
to Italy.
before this problem started?
No.
Okay. All right. Do you have any family history, any family um, problem that is any family problem that has to do with coughing?
No.
Okay. And no family issue of any cancer or anything like that?
No.
Okay. Do you have any? Do you what kind of job do you do
I work in a shop.
in a shop? Okay.
Yeah.
And how does this condition affect your shop, your business?
Quite really, yeah. So I'm not able to, you see, the customers because they will be annoyed if I will infect them or something.
Oh, okay. Oh, I understand. I quite understand. We'll see how can do to help you about that.
Thank you.
What of your marital life? How is it affecting your marriage? Are you married?
Yes.
How is it
It's not.
affecting your marital life and your daily
It's
life?
fine. No, it's fine.
It's fine. Okay. All right. Do you mind if I examine you?
Yes, please.
Okay. Can I please? I want to first of all do a general examination on you. Can I see your hands, please? Any finger
Uh,
clubbing?
no, there's no clapping.
Okay. Look at the nails. Look at the nails. Check for any the hands. Check for the pulse. Size the pulse. Is the pulse normal? The BP.
Yes, normal.
Okay.
Blood pressure is
Then
normal.
okay. Then go look at your eyes. Check for pallor. Any pallor?
So this is the face on the site. I sent a picture on the group chat and in the chat box, and there's no color.
Okay. Right. Is a female? Okay.
Yeah, female.
Okay. Yeah. Okay. What of your any? Are you seeing your menses with any menstrual changes?
Sorry, I forgot to tell you. I've been I had seen. I had they call it polyp in my nose.
Okay. All right. Okay.
That was in when I was young, but it wasn't bothering me. So like they didn't do anything.
Okay. I said you've not have any bleeding from the nose at all.
No.
Okay. Okay. Well, do you sometimes have any sneezing? Do you sometimes have some pain around your nose area?
Like pain, you mean, or what? Sorry?
Yeah, pain around
Pain in
your
my nose. No, I don't have
yeah
pain in my
inside.
nose.
Okay.
Sometimes
Okay.
it's I get sneezy as you
Sneezing.
asked me.
Okay.
I get sneezing,
Okay.
yes, frequently.
Okay. All right. I want to look at the nose and see check. Okay. I've noticed the nose. Then look at the nose, check for polyps. Then look at the mouth, check for any cyanosis. Then check for dehydration. Then look for the lymph nodes. Any lymph nodes?
No lymph nodes.
Okay. Then go to check to the chest. Examine the chest and then check for the expansion. Check for
What do
the
you okay, expansion is symmetrical.
Okay, check for the scar. Any scar, look at the scar, any scar in the chest, any previous scar. Then go
No
to check for
scars.
check for the donors, the pacos for donors, and check for the any added sound.
So there is the percussion note is you can say it's slightly dull on the left lower.
Left lower, donors on the left lower.
And yeah, and the auscultation there is coarse crepitation on the left lower.
Quartz crepitation left lower. Okay, quartz crepitation left lower. Okay. Then do you have any leg swelling or facial swelling?
No.
Okay, and no difficulties in breathing, like you said. Okay, then I want to
No.
after then I'll go to the after I finish checking on the chest, then examine the check for the BP. Okay, I've checked the chest both back and front, and it's got the same thing, the same findings too posteriorly, right? The same findings posteriorly.
And no, so anteriorly it's normal chest expansion, no added. It sounds air entry is normal, symmetrical.
Entry is normal. Oh, okay. All right. Okay. Then once I'm done, I have to now go to the
What else from the back you want to examine in the chest?
the chest. I want to look at the.
There's something important.
Yes, I'll check the inspection, expansion, and
No,
check
you
for
did
the
that.
the percourse too. Yeah,
You
then
did.
auscultates too for both both tactile vocal resonance
Yeah.
and
So
vocal
vocal
resonance.
fremitus is actually increased on the left, and
Okay.
vocal resonance is you feel it's increased left.
Okay. So more of consolidation findings there.
Yes.
Okay. Okay. Then all right. Okay. Then can you please do you have any concern, please?
So, doctor, this cough is actually 1 year, so I didn't expect that it doesn't go away.
Okay.
Will it go away?
That's a good question. But if I may ask, do you have any night sweats?
Yes, I told you 6 weeks ago.
Night sweats. Okay, I have night sweats 6 weeks ago. And do you have any contact with someone that has been coughing for a very long time?
No, actually.
You have, okay. And why you said you traveled recently, but
It's
not it was
Italy.
after.
Italy.
Was it after your problem started or before your problem started?
No, it's during. It's fine.
Doing when your problem started, right? When you traveled to Italy, was it before your problem started or after your problem
No,
started?
it's not before. It's during after the symptoms started.
Started. Oh, okay. All right. Okay. Looking at what we've said so far, I think we are having a condition that it tends to,
2 minutes
you
left.
know, yeah, it tends to, your body tends to, is kind of, your body defense, there's problem within your body defense mechanism in which your body is trying to fight against itself. We call that condition, um, is more, we call it could be, that is what could explain your childhood asthma that you had, and then most likely it could be also due to an infectious process going on there. That's why you're having this greenish sputum that's been persistent for a very long time. So what we'll do,
So,
we're going to do a chest a picture test for you on your chest, take some sample from your cough, then start you on some antibiotics, and then we're going to get you reviewed by the lungs doctor and also some specialized nurse that will be in charge. And then depending on the outcome of your result, we need to admit counsel you further on if you benefit from chest physiotherapy and some other line of management. How about that? Do you still
will
have any other
admit?
concern? Pardon? Yes, we
You will-
because for now, depending on the outcome of your results, that will see if we're going to do some tests for you, depending on the outcome of your results, we'll place you, we'll look, since you have this cough, we'll check your urea level, we'll check your which some part of your blood test,
Okay.
and see if you qualify for admission. By this point,
So,
we'll have to keep it for observation until after we see the result, and then that will tell us if we admit you fully or
okay.
not. Any other
Okay.
concern?
Could be cough. Could be asthma.
Yeah, like I said, yeah, it could be that you asthma you're having is more like it's a worsening, it's more like it's a worsening of the asthma that I had, but this is called an infection now causing the worsening of the asthma. But since there's no wheeze, I didn't hear any wheeze, so it's unlikely to be the asthma, basically.
Yes, sometimes I have wheeze.
You have wheeze, okay, but now when I listened to you had, sorry, your chest, I didn't feel any wheeze. So being that I didn't feel any wheeze, it could be what they call a cough variant asthma. But like I did, we'll do some
Okay.
we'll do some function tests for you, and then but for now, we'll just observation first. Yeah,
Yeah,
thank
yeah.
you. Any other concern?
Thank you. That's the examiner.
Okay,
So,
time is up. Any other concern, Dr. Abdullah? The last concern?
no.
Okay, the examiner questions.
So, yeah, so very brief the explanation and tell me the differential diagnosis.
Okay, this is a 50. This is a
50 years.
years old. Yeah, 50 years old Miss Julia Smith, who presented an account of 1 year history of persistent cough with greenish sputum, and there's issue of fever, and who has had childhood asthma, on currently not having any, childhood asthma. However, on with recent travel, which with recent travel to Italy, and then the on examination finding is not in any obvious respiratory distress. The nose appears, there's a beaking of the nose, and there's with nasal polyps. And also on a chest examination, there's dullness in the left lower lung zone, fast crepitation, and increased fecal formation, which is capable of consolidation of the lungs. Most likely, my first differential diagnosis here is what my first differential diagnosis is a condition called.
Before you say the diagnosis, this cough has been worse by it's continuous all the time, and it's greeny. So it's really you need to think what is the first possibility likely in this.
I must say, because of the acute exacerbation of acute exacerbation of, although it's a chronic thing. I'll go with, since the symptoms is more like a chronic thing. I had a childhood issue of asthma which was treated. I will go with chalk straw. However, with superimposed with Pseudomonas infection.
Sorry.
Superimposed with Pseudomonas. Superimposed with Pseudomonas. And also other differential diagnosis could be granulomatosis with polyangiitis, which is a
was what?
chalk straw.
Okay.
And then also looking at it, because of there's no evidence of the chest, and when I examined the chest, there was no barred chest, and also consider acute exacerbation of COPD because of the prolonged chest complaint. However,
consider more likely.
You said what? Sorry.
So, can you say the differential diagnosis again? So
I mentioned I mentioned COPD, acute exacerbation of COPD. Yes. Also, I also mentioned chalk straw, which is a eosinophilic granulomatosis with polyangiitis, and because of nasal polyps, although there's no, I also go with granulomatosis with polyangiitis, which is Wegener's granulomatosis. However, there's no kidney manifestation. Also, these are and then acute exacerbation of asthma, because he has a background asthma. These are the things I want to consider in my case as my differential diagnosis of them.
So how you will investigate?
Investigation, I want to start by doing bedside bedside pulmonary respiratory function, checking the SpO2, the lung function test. Then I want to do chest X-ray, sputum AFB, sputum MCS, sputum cytology, and sputum for focal lung studies. And then I want to do also do for auto antibodies like
is there any something you said you'll do sputum? Very good. Anything apart from sputum before going from the patient side? There's something really important in this patient.
Yeah, I mentioned lung function test and arterial blood gas with SpO2.
What else?
Arterial blood gas. That is a lung function test, including the
there's something that help you in diagnosing the patient and guide you. Very important before you go.
Yeah, chest. I mentioned chest X-ray. I mentioned chest X-ray. I mentioned chest X-ray. Yes, chest X-ray. Then chest CT scan is ECG, and then
watch.
Pardon?
CT, you will look for what? For the CT, you will look for what?
Yeah, for the CT, in this case, I would see for evidence of if there's any bulle, check for the evidence of changes and changes in the lungs, like if there's any cavity, basically, if there's any cavity in the
Okay.
lungs, lung cavity, yeah, the lungs, to
Uh,
also exclude pulmonary TB.
how you will manage?
Management, we involve the multidisciplinary approach, involving the pulmonologist, the specialized nurse, the chest physiotherapist, also involve the occupational therapy, and then also we want to admit this patient for observation and start oxygen if the SpO2 is reduced.
Okay.
We'll place him on antibiotics depending on the COP 65 if it's in keeping with parenteral if the COP 65 if the urea and if the respiratory rate are in keeping with COPs, if it's more than two, want to start with parenteral antibiotics. If it's one or less than that, we'll start with oral antibiotics. And then if it's more than three, four, five, we want to admit in the ICU and
So you
commence.
you will start antibiotic. Say you have the CRP, the lab is still waiting. What will you think? Would you start empirical antibiotic before even, based on your clinical assessment, would you?
Yeah, based on my clinical assessment, being that it has a greenish sputum,
Okay.
I'll think of pseudomonas, anti-pseudomonas. So I want to start with antibiotics cover first
Would
of
you
all because of this, because of
try
the
a
greenish sputum. Yeah, trial of antibiotics.
good? Okay. What else? Do you do any other management?
Then other management based on the fact that he has a background asthma, I want to commence him on steroid, and yeah, basically steroid, and I
Okay.
think yeah, basically this is what I would do.
Okay. Um,
Okay,
okay,
you're
good.
done, Dr. Abdullah?
Yes.
Okay, you can comment now.
Okay, thank you. You did well. You have okay. So first, this case is about this Miss Julie Smith is a middle-aged lady. So she had 50 years old. She has a chronic cough, productive. So actually, in the history, there is something make this cough worse, which is lying down. So it's a positional cough. And you are quite true when asking about is it worse at night? That will help you. Is it asthma, more asthma related? Because there is cough variant asthma. If it is more lying down, that will put possibility that she is having a complicated post-nasal drip. So although it's dry, it should be, but if it is productive now, then there is something complicating this post-nasal drip, making it worse with positional. So also there is wheeze in the history, and you didn't ask about chest tightness. Tightness here is important because it will indicate is this could be asthma or although cough alone is also indicative. Wheeze also there is, and there is you asked, so there is wheeze, and I'm not sure. You asked about is it in something intermittent or fluctuating, and is it something continuous? I think you asked that, yeah. There is night sweats, which is different from fever, and that indicate there is infection happening. You detailed on the nasal symptoms. That's very good. You asked about there is also allergic symptoms happening, nasal, runny nose, and so given the examination, there is only this nasal bridge depression. Could be something important, or could be just something not important. Like it could be something not pathological. Also, there is the chest findings indicating the consolidation signs of consolidation on the left side. On the history, on the history, I'm not sure if you detailed on the, so in the systemic review about the reflux symptoms, because here it's important. Also, we are going now to, in the history also, you didn't ask about recurrent infections. And that's important that to rule out, like to indicate bronchiectasis. Is there any family history of allergy? Did you ask family history of allergies? Now going to the differential diagnosis, respiratory infectious disease should be considered now. With the history of night sweats at 6 weeks. I think this first, it's actually a real case, but it's not diagnosed yet. Like we have an immunology workup waiting for this lady. She is stable. She came to the hospital for workup. So as you said, you will need admission to rule out other serious conditions, and then you will go home. So the differential, we were thinking like, is it cough variant asthma? But in this, against this, it's not nocturnal, and the symptoms are continuous, like they're not fluctuating. Other differential, complicated upper airway cough syndrome or postnasal drip. And then other causes such as bronchiectasis, although it didn't show bronchiectasis actually, CT, and there is gastroesophageal reflux, chronic bronchitis, hypersensitivity pneumonitis. Yeah, she actually works, you didn't detail on the job, she works in a shop with bodybuilding substances, which could be related to her illness. And that's for years she's working on that shop. And also there are, you didn't ask about pets at home. You need to detail on the allergens at home. She doesn't have. Does she have any also other occupation before that shop? So she was exposed also to dust repeatedly. So maybe related, maybe not. I think that's about, so the management and this, so the differential diagnosis, you said actually commenting about you, so I will give you 1 for differential diagnosis. It's not 0 because it was correct, including correct diagnosis, differential, but you should say first the asthma, not in the end. Like this lady has feature, she doesn't have barrel chest, she doesn't have hyperinflated chest, so no need to see COPD first. Or Wegener's. Wegener's is very less likely. She only had that polyp, which is very common, and it doesn't mean that she has Wegener's. And also, she doesn't have other systemic features. She only had some night sweats recently. Could be from the infection, consolidation that she had complicated her condition. So she doesn't have other systemic renal or other something that indicate Wegener's. And if she has Pseudomonas, she's more likely to be a sick patient. Like she's stable, and she doesn't have a picked up high degree temperatures, and she has this 6-week night sweats. I mean, less likely could be serious bronchiectasis with Pseudomonas with no previous risk factors also. So differential diagnosis, so it's better to say asthma more on the top, and to also, you can say Wegener, but in the end of the list, include other causes, gastroesophageal reflux. Asthma, I would say, is a reasonable differential diagnosis, asthma, cough variant asthma, and then you say other causes. Even if unrelated, gastroesophageal reflux disease, chronic bronchitis, and bronchiectasis. Judgment 1, because I think the peak flow meter is very important on the bedside. It will help you, is that asthma related or not? The patient, even if she's not wheezy. So in also management, you did well. You perfectly included everyone, multidisciplinary team, and a trial of antibiotic. That's very good, actually, and also a trial of steroid. And in this case, being postnasal, you will had antihistamine trial and also um, I forgot actually antihistamine and decongestants. It, as a trial, that's the management and with antibiotics, and then you need to detail on the immunology workup. So you will send. You said that autoimmune workup, yeah, perfect. That's about it.
Thank you.
Sorry.
Thank you.
Okay, thank you, Dr. Abdullah. So I can comment quickly on Dr. Henry performance. For the analysis of the complaint, he didn't cover all the points, the time, the night, the timing, what increase, what worse, the triggers, the chemicals, the relation to the job, as Dr. Abdullah mentioned. You are speaking about asthma, features of asthma, and the patient is already known asthmatic. You didn't even ask patient if he has or she has noisy breathing, ongoing noisy breathing, which is asthma sound or asthma features. On top of your differential, you should include the asthma or recurrence of the asthma or some triggers to the asthma or occupational asthma. All these can fit the differential. You can mention them. Again, if you mention the trigger, the pet, birds, exposure to any foams, any substance that can lead to this cough, you have to speak about and to analyze them more, which you miss, okay? Even the acid brush you didn't ask about. GERD is a joker. You can put it in any cough patient as a differential. Most of patient or people having GERD. So you can ask about any acid brush or feeling tasty in your mouth. Post-nasal drip, the patient was volunteered to mention it, so you can put it as a differential. Okay? This is regarding the complaint and the analysis of the relevant system. Constitutional, you cover, so you speak about the night sweat, so it can give you a clue there is ongoing infection. And you can put one of the differential as infection, okay? The systemic review question was good. Past medical history, I think you cover, right? The medication list also you ask, the surgical, the admission, the hospitalization, a recurrence, or any history of infection. Once you have history of infection, you have to know why and when, since childhood or adulthood. What the problem? What the significance of this, Dr. Henry? If you have patient with infection, recurrent infection since childhood, what does it mean?
We think of bronchitis can be
Yeah,
one of the
exactly. So bronchitis is related to the immune deficiency,
yeah.
gamma globulinemia, right?
Yes.
The other thing is, yes, even contact with sick patients, you have to ask. It's important to rule out TB, even it's not the case. You mentioned Wegener, which is not fitting this differential because the Wegener usually they present with hemoptysis. And you ask about coughing blood. Patient denied that. Yes, there is deformity in the net in the nose, but does it mean that you might have Wegener because of this deformity? Okay. The examination, I think you cover the examination. Since you have consolidation or increased vocal resonance in a loop or in a zone, you can mention consolidation and pneumonia, and this can be as a differential. But for the long term COPD, you have to have the finding of COPD. Even nicotine staining, you have to mention while examining the patient, along with the clubbing and other finding of COPD. Barrel shape, as Dr. Abdullah mentioned. It's a case of differential. It's a good one to discuss and to review the cause of cough. But don't forget the joker. GERD, one of the important differential in any dry cough. GERD and asthma. Whenever you mention asthma, you have to know the differential of asthma. Asthma or occupational asthma or drug-induced asthma. I like when you ask about over-counter medication. Why? Because some of non-steroidal or non-steroidal in some patients can lead to asthma, right? So you can put it
Yeah.
as a differential as well. Drug-induced asthma. You might have a patient with newly started medication, non-steroidal over-counter, and the asthma comes while he's taking this medicine. Okay.
Okay.
The differential, I think Wigner out of the differential, you cannot, but if you want to mention, you can mention drug-induced asthma itself, or occupational asthma, or post-nasal drip, or GERD. I think these are the differential of our case today. If Dr. Abdullah has another differential, he can mention. Dr. Abdullah, anything else? Pneumonia, you mentioned, yes, infectious, ongoing infection. Even the infection, chest infection can exacerbate the asthma. So you can mention, yes, asthma exacerbated by infection or exacerbated asthma. And if the patient recently admitted to the hospital, you can mention hospital acquired, or if the patient comes from the community, you can say community acquired pneumonia. Okay, these are the case today, differential and everything. I will read the comments quickly. COPD exacerbation, COPD bronchitis. Bronchitis, you have to have cough, productive cough, and the amount will be high. Uh, what else? Yeah, I asked this question as differential. I meant the differential of GERD, gastroesophageal reflux disease. You have to mention and to ask and to roll it out. Bronchiectasis, Dr. Ahmed Mustafa. Yes, you can say in the long term, if the patient is having chest disease, long-standing chest disease, bronchiectasis can fit the differential. However, it's not. You can say localized bronchiectasis. There is localized bronchiectasis. So the patient will have cough, expectorant or productive cough, and yes, it can be white or yellowish discoloration, and the amount will be high. Okay, cough with lying down, post nasal drip, and GERD. Exactly right, yes. And you can add to them, as I said, asthma. Asthma, the patient usually cough at night. Okay. Why admission? Patient stable, complain for 1 year. Why admission? Yes, I agree. No need to mention the admission. You can say, I can admit the patient to the emergency to do some blood test, ABG, spirometry, peak flow meter to see if this patient is having asthma exacerbation or no. If patient need to be admitted, you can mention I refer the patient to chest physician and the group of doctor multidisciplinary team approach, and the decision will be after that. Okay, Dr. Ahmed Mustafa again. Is it dry or productive? It was dry, productive one. It wasn't clear really. It was both of them, dry early, then wet later. What's the cause of green phlegm here? Pneumonia, Dr. Abdullah mentioned pneumonia, complicated sinusitis, or both. 1 year pneumonia. No, it was recently only complicated. Likely sinusitis ongoing first. Okay. Any question or comment from others? We are done with the comment as well as with the chat box. Anyone want to add any comment?
Yeah, Dr. Bazim,
Yes.
thank you for your comment. I'm just a little bit, because of the issue was not because somebody having greenish sputum production, not very
Mm-hmm.
much though, for 1 year. I was thinking that the diagnosis itself should be a chronic diagnosis, but looking at the issue of even the fever that he said was 6 weeks, is still chronic in the sense of a chronic fever too. But the examination findings is looking more of a pneumonia, which in quotes, pneumonic is usually more of an acute presentation than a chronic, So could it be what is now making because somebody cannot be having that 1 year history of mnemonic
Okay.
changes.
Yeah,
I'm just,
I will tell you,
could it
Dr.
be,
Henry,
yeah,
it's not a
mhm,
matter of one diagnosis. Usually,
yes,
those cases are coming as a differential, a case for differential.
yeah,
So whenever
yeah,
you mention the three important differential diagnoses in this case,
Mm.
So you want to roll them out one by one. This is the most important. Not importantly to put the first or and the only diagnosis. No, it's not a case of first and one diagnosis.
Yeah.
So- okay, so you have to mention
Okay.
the asthma. They want you to think more. You want to
Yes.
put differential of asthma. Yes, could be an asthma exacerbated. There is pneumonia possibly because there is consolidation. And usually
Mm.
correlate your finding in the history
Mm.
along with the examination finding. So you are saying to the examiner that based on the finding, the history finding, along with the history on examination, along with the finding on examination, I could think about one, two, three. So it's not a matter of finding only, history finding only. It's not a matter of examination finding only. Both of them just try to link why this is there and why that was in the history. If you put them in this way as approach, believe me, you will get good mark. Even you didn't put the one or on top differential. Okay, but you have to put the most relevant. Don't say Wegener as in this patient. Based on what Wegener because of nasal drip. No, we have to have another finding of Wegener like uh, hemoptysis, kidney infection,
Okay.
right? Sinusitis and this stuff. Clear? Any other question, Dr. Henry?
Okay.
Okay, thank you, Dr. Henry. Dr. Abdullah, anyone has comment before ending the session?
I have a sorry,
Yes,
just
yes.
Dr. Henry, there is a when you felt the coarse crepitation, in this case, with green sputum, uh, immediately ask to cough and then see if there's any change or or did it disappear.
Yeah.
It really help you. Like you'll be almost sure this is bronchitis.
Yes, it's not
Yeah.
in this
Thank you.
case only. In any chest case scenario, whenever you have cough, ask the patient to, sorry, whenever you have crackles, ask the patient to cough. If the crackles changed, means this is bronchiectasis. If doesn't change, means this is fibrosis. Okay? Okay. Thank you, Dr. Abdullah and Dr. Henry. I will just add one comment. This week, we will do 5 days. So starting from Saturday, Sunday, Monday, Tuesday, and Wednesday. We will do two long and two short, and uh, two long and two communication, and one short on Monday. So in order: Saturday long, Sunday communication, Monday short, Tuesday long again, and Wednesday will be for the communication. By this, I will try to fix this format all over. So we practice every day the long, the short, as well as the communication. So the Friday and Thursday mostly will be off till another announcement. Okay. Thank you, Dr. Henry and Dr. Abdullah again. Thank you everyone for attendance. See you tomorrow, inshallah, with the communication day. Good luck and good night. Assalamu alaikum wa rahmatullahi wa barakatuh.
عليكم السلام ورحمة الله.